Good evening, everyone, and thank you for joining us for tonight's Woo You event with the one and only Mila Brujic, one of our most widely requested speakers, and for a very good reason. He's going to be speaking on dry eye disease, diagnosis, and treatment pearls from the trenches. My name is Dr. Ariel Sorenzi, and I'll be your host tonight. So I'd love to introduce our speaker tonight. You're missing a big part of your bio. Where's the rest of it? I feel like this is just too simple for all of the things that you've accomplished. So Dr. Mila Brujic is a graduate of the New England College of Optometry. He is a partner of Premier Vision Group, a successful 4-location optometric practice in Northwest Ohio. He practices full scope optometry with an emphasis in ocular surface disease management of the anterior segment and specialty contact lenses, and is active at all levels of organized optometry. He's on the editorial board for a number of optometric publications and has published over 400 articles and has given over 1,900 lectures, both nationally and internationally, on contemporary topics in eye care. Here are his financial disclosures, all of which have been mitigated. So I'll have you take it from here.
Thank you, Ariel, and thank you all for joining me this evening. This is arguably one of my favorite courses to give because this is going to be 50 minutes in the trenches with what I would argue are some of the most important clinical pearls when we're talking about dry eye disease, both not only in the diagnosis, but also treating these patients as well too. For those of you that treat dry eye patients on a regular basis, for those of you that are doing it heavily in the trenches, for those of you that are kind of peripherally managing it, or for those of you that are really interested in developing this facet of your practice, it is important that you start viewing these individuals just a little bit differently because the ocular surface, in my mind, and the reason why I was passionate about it from the day I graduated optometry school, is because it involves every single piece of what we do throughout the care of our patients. Not only does it need to be optimized for the surgical patients, but also for those individuals that are glasses or contact lens wearers because of the way the eyes feel and also the way the eyes see. I learned this from a tough learning lesson early on where a patient came back and wanted to return glasses that I had prescribed to her because she couldn't see well out of the glasses. And what ended up being the case was that she had unstable tear film. Now, back in 2005, we didn't know a lot about dry eye disease, and we thought it was either aqueous or evaporative dry eye, or we used to call it a lipid deficiency, or we used to say there wasn't enough aqueous being produced. And we now know that it's much different than that. That's a very academic way to describe dry eye disease. But I want you guys all to look at this image right here and paint this in your mind as we go throughout the rest of the discussion, because every single thing that I share with you tonight, every single time we make a decision for a patient, what we're looking at is trying to take all the diagnostic information that we gather or capture from that patient with either advanced diagnostics or slit lamp evaluation, usually a combination of the two. And we're then asking ourselves, what's the majority of the reason for this individual's abnormality? Is it more aqueous deficient or is it more evaporative in severity? And as you can see, most dry eye isn't necessarily clear cut and dry one path or the other. It's usually a combination of the two. So again, what we're trying to do clinically is just look at these individuals and figure out what's going to give us the most bang for the buck with these individuals in terms of helping these patients and treating these individuals. And the conversation would be incomplete if we didn't talk about the lid margin, which is what we're actually looking at here. Now, I will share with you one thing that I've shared over the last 5 years, and that is the fact that I feel that I was incorrectly taught how to assess the lid margin. What do I mean by that? Well, in optometry school, I was taught to look at the lid margin at a low magnification, a 10x, and do it with a wide beam. And if you do that, you'll see the image on the left-hand side, which is a low magnification view of a patient. And for those of you watching this right now, you're probably thinking, okay, there's nothing really wrong with that lid margin, and I don't think that that's contributing to the patient's symptoms. Now, on the right-hand side, all I did was crank up the magnification, and you can see what a higher level of perspective you just received just from turning up the magnification on your slit lamp and seeing what those actual collarettes look like. I'll give you one other example here of an individual who You probably saw a dozen of these today in your practice. And when you look at that lid margin, you wouldn't necessarily call this patient a severe blepharitis patient. You wouldn't necessarily call this patient having significant collarettes. This is at the low magnification. Let me crank up the magnification one step. You can already see that you're gaining a greater appreciation for what the lid margin may actually be contributing to the patient's symptoms. Now, let me give you one more step of magnification. Same patient. The only thing I'm doing differently is showing you this lid margin at increased magnification. I have one more. Same patient. Again, you get a better sense of what's going on at the lash and lid margin when you not only look at it with a low magnification, but you also increase the magnification. So why do I share all of this? Well, prior to September of 2023, we really didn't have a way to effectively treat and cure the condition causing or forming the collarettes on the lash margin, which is an overpopulation of Demodex. Today, we do. It's lotilaner at 0.25%. It's branded as XDEMVY, and it's prescribed as 1 drop BID OU for 6 weeks. What I typically tell patients is, because it's in a 10 ml bottle, is I tell patients, although I write the prescription for 6 weeks, I tell the patient to use it until the bottle's gone. I prescribe it, and I usually see the patient back 2 months later. That will usually be enough time for the patient to actually access the medication and usually have that full 6 weeks. So what I'm seeing that patient at in 2 months is when they've been using it, usually for that full 6 weeks. And you'll see the power of lotilaner. Now, what's interesting with this medication is that you use it on the eye just like a traditional eye drop. So you don't have to put it on the finger and rub it into the lash margin. Use it like a regular eye drop. And because of the formulation or the intelligence of the formulation, it actually finds its way into the lash follicle where the Demodex reside. And it is toxic to Demodex. And the reason why we take it for 6 weeks is because it kills both life cycles of Demodex, not only those that are living right now, but those that haven't hatched yet, and they will be hatching shortly. It's interesting because this has all been an evolution of understanding over the last decade. Jim Reinerson and Hank Perry actually produced this paper called The Dry Eye Blepharitis Syndrome, a unification theory for dry eye. And they actually discussed this over a decade ago about this biofilm that starts forming at the lash margin and creeping back into the meibomian glands, then on the ocular surface. And they were proponents of truly understanding the health of an ocular surface being the cleanliness of an ocular surface, or directly associated with the cleanliness of an ocular surface. So they created microblepharoexfoliation, which is literally a tool that gives us the ability in a sitting with a procedure in the exam room to clean those lash margins. It's interesting what we've learned with about a decade of experience with microblepharoexfoliation, and studies have come out now supporting a lot of this. And this was an interesting study. I originally read this a little over a year ago. It was actually right before the Ocular Innovation Summit at SECO. And I'm going to share with you why that's important in just a few moments here. But what they did was they found that individuals with a chalazion, if they either randomized them to a group that received a BlephX treatment, versus no BlephX treatment, had them both utilize lid hygiene for a month, 87% of the group in the BlephX treatment arm actually had complete resolution of their chalazion in 1 month versus about 33, or a third, of the patients in just the lid hygiene group. This is one of the ways that we can actually treat individuals non-surgically for chalazions. Some of you may be wondering, well, how could a BlephX treatment actually cure or help alleviate a chalazion? We're going to talk about that in a few moments here. So to take a step back, we're really kind of floating into the diagnostic space, and then we're going to keep going into the therapeutic space when things are appropriate. What I want to share with you right here is really what I would refer to as the everyday diagnostics that we have that I feel sometimes are underutilized. Our fluorescein dyes, our Rat number 12 filters, our lissamine green stains, our cobalt blue settings on the slit lamp. You can see things that are literally invisible with these tools. This is a patient who, again, doesn't really have any type of or significant level of corneal staining, but you can see the tear film breakup time is substantially reduced in both the right and the left video. This is something that's invisible without utilizing fluorescein dye on the surface of the eye. Every patient that I see in my chair receives fluorescein placed on the lower palpebral conjunctiva, and we examine them with a cobalt blue light and a rat number 12 filter to see what the quality of the tear film is, and also to determine whether or not there's any conjunctival or corneal staining, as you can see here. There's other dyes that we have access to, but fluorescein is by far the one that's most utilized in our office. Now, there's other things that we can actually see with the vital dyes. That's something referred to as lid wiper epitheliopathy. Now, for those of you who are unfamiliar with this term, we need to just do a quick review of anatomy. And one of the most important anatomical markers on the superior lid is something referred to as the lid wiper area. This is the small area on the upper eyelid that actually wipes along the ocular surface as somebody blinks. And what Don Korb literally demonstrated 25 years ago was that in a patient that has dry eye, if they're symptomatic for not only contact lens dryness, but just eye dryness in general, 80% of them will show some level of lid wiper epitheliopathy. All lid wiper epitheliopathy is excessive friction, again, along that upper lid margin where it's rubbing against the ocular surface. Now it's irritated and it's uptaking vital dyes. That can either be lissamine green or fluorescein, and you'll actually see it with both of those. He actually proposed a grading scale for this, looking at the horizontal length, and you can see the grading scale on the right-hand side versus the sagittal width of the lid wiper epitheliopathy as well. And the sagittal width is really the percentage of the staining that occupies the lid wiper area. So these things aren't necessarily the cause, or these things aren't necessarily the reason that somebody has dry eye, but these are the things that are downstream ramifications of ocular surface disease and dry eye. And they're things that we're trying to and attempting to improve as we treat. We are in a plethora, a hurricane, a tornado right now of technologies that we have available to us to look at the biochemistry around the tear film chemistry to help us determine what we should be doing with these individuals. One of the tests that I hold near and dear to my heart is the inflammadry. It measures levels of MMP9 in the tear fluid. It's quick. It's usually administered by a technician. And in our office, what we do is we do a test at the time of diagnosis and also every single time we follow up with that individual. And essentially, the way the test is performed is you actually acquire a sample from the lower palpebral conjunctiva, you snap it into a sample collector. Then what you do is you dip it into a buffered saline. You can see that right here on the bottom left. And then on the bottom right-hand side, you can actually see you wait for 10 minutes for that test result. This is showing two tests that were adequately administered. The bottom one shows a negative test because there's no red line, and the top one shows a positive test because it shows a red line. The blue line is simply a control line. It tells you that the test was performed correctly. If, for example, there's no blue line, the test was performed incorrectly or there's something wrong with that actual test. Now, what is that red line measuring? Well, it's measuring levels of matrix metalloproteinase 9. And this is an example of what you'll see in your office if you perform inflammadry testing. You can see that this individual has different levels of intensity to that red line on the right eye and the left eye. You can see that that left eye, the red line is much brighter, and in the right eye, the red line is much duller. Well, why is that? That red line is a well. It's an antibody well, and it literally has antibodies to matrix metalloproteinase 9 protein. So if somebody's MMP9 levels in their tear film are elevated, you tend to have a red line here. If they're highly elevated, it's actually concentration dependent. You'll just literally get a stronger signal that's present here. And again, when we blow this up or magnify it, you can see the difference in signal strength that's present there. So why is this important? Well, Dr. Kading and I saw this very, very early on when we first started using inflammadry. And we actually created a scale that we presented at Global Specialty Lens Symposium back in 2017. I can't believe it's 7 years ago already. But what we did was we worked with the company and said, hey, can we get samples or quantities of different strengths of MMP9s and run the test and see what it looks like? And what you can see here is as the concentration of MMP9 increase in that controlled buffered saline, you actually increase the intensity of that red signal strength. So every single time I see a patient, I'm grading the signal strength as either negative, which is no red line, a trace positive, which you can barely see it right here, a weak positive, which again, the red line in intensity strength is much lower than the strength of the blue line, a positive, which is where the red line and the blue line are about equal in intensity, and then a strong positive where that red line actually supersedes the strength of the blue line in terms of the intensity. Now, there are other point of care tests, and one is the Scout Pro by Trucara. And essentially what this is this is the newest version of osmolarity reading from a company that used to be referred to as TearLab. What they did here when they designed this was they said, let's take out all of the other factors that are difficult to control for, things like temperature, things like the humidity, and let's make it so that it's very, very easy for the clinician to actually perform this in a repeatable way. And that's what they did with this test and the newer version of the test. There's two new kids on the block here that are important to go over. POC stands for point of care testing, and this first one tests for lactoferrin levels. Lactoferrin levels are actually reduced or very, very low in an individual that's believed to have aqueous deficient dry eye, 0.9 micrograms per milliliter or less. And for those who have dry eye but have greater than 0.9 micrograms per milliliter, they likely have appropriate aqueous production. Why is this important? Well, remember that scale that I showed you earlier and that grading system. If you have and measure lactoferrin levels that are low, you're more likely to want to promote tear production. If you have lactoferrin levels that are above that 0.9 microgram per milliliter threshold, now you're thinking there may be something else with the biochemistry that's causing the patient to have dryness. You're looking much closer at that lid margin at that point for some form of evaporative dry eye or meibomian gland dysfunction. There's another point of care test now too, and I wanted to at least touch on this because it utilizes the same platform. And although it's not dry eye, it helps us differentiate dry eye. And it's actually tests for levels of immunoglobulin E, which we know are highly upregulated in times of allergic eye disease. All right. So we're looking at all of this diagnostic information, and we're looking at things at the slit lamp. And we talked initially about increasing the magnification at the surface to make sure that we're dealing with a clean lid margin and lashes. But one thing I intentionally skipped because I thought it really warranted a section of its own was the meibomian gland, the lid margins, and what those actually look like. Now, always remember when we talk about meibomian glands, there's two things that we need to be thinking about: the structure and the function. Think of meibomian gland dysfunction as being the ocular surface analogy to glaucoma. You'd never treat a glaucoma patient and never do an OCT. In that same vein, you'd never treat a glaucoma patient and never do a visual field. So we're thinking along those same lines with the lid margin. So how do we assess function? Well, the first thing we do is we look at the lid margin for any signs of what's referred to in the literature as obvious meibomian gland dysfunction. That's what you see here. You see visible capping along the meibomian gland orifice, and you can see several small little caps and then that one large cap. You know there's issues with the meibum because there's a physical blockage of the meibum as it's attempting to leave the orifice. But how do we, in a more controlled way, assess the functionality? Well, we do it by applying light pressure along the lower lid and the upper lid margin. We can do that very, very easily with just our thumbs and our fingers, or we can do that in a more controlled way with something referred to as the meibomian gland evaluator. The meibomian gland evaluator, you can see here on the right-hand side, is a tool that was initially put out by a company called Tear Science and is now owned by Johnson & Johnson. But it allows you in a very controlled way to assess that lid margin and the meibum that's actually flowing from the meibomian glands. And this is an example of what it looks like here. Now, what you have here is an example of an individual who has non-obvious meibomian gland dysfunction. Why do I refer to it as non-obvious? Well, the lid margin really doesn't have any telangiectatic vessels. It's not inflamed, and you don't really see any visible capping. So if you were to just examine this lid margin, you'd say, all right, this patient's normal. And if this patient's having symptoms of dryness, you'd say, okay, it's not because of misfunctioning or a lack of appropriate meibomian gland functionality. When in actuality, It is. And the only way that you can test for that is testing functionality. So build this as a process during your examination so that you can assess those lid margins and see, in fact, what's coming out of the meibomian glands with either a finger or with a more controlled tool like the meibomian gland evaluator. But the second thing that's important here, and I'll tell you why it's important, is to assess the meibomian gland structure. Why this is important is because it helps set the precedent for communication of how we're going to be caring and treating for this individual. What this is literally doing is it helps us guide the level of success versus the guarded prognosis for these individuals. If somebody has long, healthy meibomian glands and they have obvious obstruction, there's a good chance that we can get those unobstructed with appropriate therapy and get them functioning very, very well. For an individual who has extremely short meibomian glands or a lack of consistency to the length of their meibomian glands and visible dropout, in these patients, the prognosis is much more guarded with these patients in terms of rehabilitating the functionality. I still encourage you to attempt to rehabilitate the functionality, but there's some more physical limitations because they just don't have as much meibomian glands that are present there. Now, here's the cool thing with meibomian gland structural analysis. And I'll show you all the fancy images from infrared. But here's an example of me just pulling the lower lid down and looking at a patient. And you can actually see here where the meibomian glands are and where the meibomian glands aren't. This is not with a slit lamp. This is me taking a picture with my iPhone. And it immediately starts to give you an impression of what it actually looks like. Even when you look at the slit lamp, you can very easily see where the meibomian glands are and where they are not located or where they're shortened. Now, one of the tests that I love to do at the slit lamp is called eyelid transillumination test. This is a quick screening test where you can assess what that gland structure looks like. So what you see here is literally at the bottom of the screen. This is my transilluminator. I'm literally using it to leverage that lower lid, and I'm shining the light through that lid while I'm inverting it slightly. So what you're looking at here is the palpebral surface of the conjunctiva, and I'm actually shining a light through the bottom of the lid. Now, the key to this test is making sure that your slit lamp lights are all off, and the only light source that you're using to examine this patient's eye is the light from the transilluminator. If you try to do it any other way, you will not see the shadows from the meibomian glands that are blocking light from going through the way that you do in this instance right here. And again, you can very clearly see where the meibomian glands are and where the meibomian glands are not. And with imaging technology or slit lamp imaging, you can actually show patients this image so that they can see where their meibomian glands are and where they aren't. Now, fortunately, we have grading systems and tools that give us the ability to assess what the level of dropout is here. And you can see on the top left, the normal individuals. So you can see full gland structure all the way down the palpebral conjunctival surface. And you can see as the degree of loss increases as you go down the left-hand side, you increase the grading of loss for that individual. Think of it very similarly to cup to disc ratio. The larger the cup to disc ratio is, the greater the chances of rim tissue that's degrading or nerve fiber layer that's lost. So it's the same type of logic that we're using there. And again, for those of you that do have infrared imaging, again, you know that we have the ability to measure this with infrared technologies. This is available now on slit lamp cameras. It's available now on advanced OCTs as well. So there's just a number of ways that we can do this. Now, it's important to understand the structure to set the precedent for therapy for patients, but there's other reasons why it is as well, too, and I'm going to show you that in just a moment here. There's really three ways that we can treat these individuals. The first is LipiFlow. LipiFlow, through a 12-minute treatment, produces, with an inflatable air bladder, pressure on the front surface of the lid while it's simultaneously warming the posterior surface of the lid or that tissue that's closest to the meibomian glands. So again, this is a very consistent, very reproducible procedure that's the same for every single patient. And again, the data is crystal clear on the efficacy of LipiFlow, which in fact it has shown over years. There's a second device that simultaneously warms and evacuates the meibomian glands, and that's the iLux device. And what you have here is a device that warms and applies pressure to the lid from the front of the lid, and you can actually view it through either a viewing window or through some of the more advanced iLux devices, now a digital display. There's a third way to evacuate the meibomian glands, and that's through the tear care system from Sight Science. And this is what I refer to as sequential meibomian gland warming and expression. So again, you're not doing it at the same time. You're warming the upper and lower lid with the smart lids, and then what you're doing is expressing with a tear care expressor along the lid margin. Now, I told you earlier why it's important to know what the structure of the meibomian glands are to set appropriate patient expectations, but it's also important to understand meibomian gland structure if you're performing any of these advanced procedures. For example, the iLux and the tear care system, they provide the practitioner the ability to express the glands. Well, you need to know where those meibomian glands are and where they aren't. So you're not waiting for something to come out of a region or an area in which the meibomian glands are not located. So that's one of the reasons why it's so critically important to understand that structure. Now, this isn't available yet, but I wanted to share with you a precursor to this technology. Remember earlier I talked to you about seeing the data on the BlephX for chalazion treatments, and 87% of those individuals actually resolving their chalazion. The reason why that I was curious about that was the mechanism of action. How could it possibly do something like that? The next week, I went to the Ocular Innovation Summit at SECO, and the individual physician who is bringing this to market was there talking about this technology, and it's referred to as the eye lipid mobilizer. So what does this device do? Well, it sits on a patient's face. You can actually prescribe the time and the amount of treatments that an individual wants. It will be something that the patient purchases and brings home, but it does three things simultaneously. It provides heat to the lid margin, it creates micro vibrations along the lid, and it also produces pressure along the outside of the nose bone. Why are those three things important? Well, heat, we know, warms the meibomian glands and the meibum. The pressure along the nose is so that you could stimulate the trigeminal nerve to create tearing or create tear production. But this micro vibration actually creates a shearing force with the meibum, causing liquefaction of some of that solidified meibum. So when you see that, you realize that that shearing force may be what's triggering that chalazion to actually liquefy and resolve itself over time. Again, the BlephX, for those of you who haven't performed this, it's a tool that actually spins very quickly along the lid margin, but there are micro vibrations along the lid margin as you're doing it. And this may be the mechanism of action that causes that chalazion to actually improve over time. So what are some other things for meibomian gland disease? There's really some unique technologies that have been brought to the market, and this is one of those. So everybody on the call knows it as MIBO. The molecule is perfluorohexyloctane. And this molecule breaks a lot of rules. I'm going to explain to you why that is. First and foremost, it's 100% perfluorohexyloctane. Why do I say that that breaks rules? We don't have anything in eye care, to the best of my knowledge, that's 100% of any given ingredient. Why is that important to understand? Well, when you look at any of the clinical data which showed clear improvement in signs and symptoms, you have to wonder, well, what was the placebo that they tested it against? Because the placebo is usually the inactives in that active formulation. So what they had to do is they had to go to the FDA and say, hey, what do you want us to use as a control? And the FDA said, let's use this hypotonic saline solution. The problem with hypotonic saline solution is hypotonic saline is actually therapeutic because a dry eye has a hyperosmolar or hyperosmolarity to it in the tear film itself. So putting a hypotonic solution on it dilutes the tear film, and it's actually therapeutic. So not only did they show statistically significant differences against a control, which isn't truly available, it showed it against something that had a track record of therapeutic. So that's the first interesting thing. The second interesting thing is that it doesn't have a pH, because it's not mixed with anything, in particular water, and pH is measured with water, you can't measure a pH on it. The third thing that's interesting is that it doesn't have any preservatives in it. So benzalkonium chloride is normally the preservative in the medications, and there's other softer preservatives. This doesn't have anything in it. Because it's 100% perfluorohexyloctane, nothing can grow in it. So what that means is it's safe in a preservative-free bottle. The one other rule that it breaks is that most of the time, we're actually used to utilizing drops that are between 40 to 50 microliters. That's a standard eyedropper. This comes out in 10 to 11 microliters. So it's a very small drop. So these are things that make this unique. Now, what perfluorohexyloctane does is it actually recreates the antievaporative layer on the surface of the tear film. So unlike many of the pharmaceuticals that we utilize in our space where it's acting on a target on a cell, this molecule's target is actually lipids in the lipid layer of the tear film. And because of that, it acts as an anti-evaporative layer, holding the tear film on the surface of the eye for longer periods of times. And where we found this to be a true gem is whenever we diagnose anybody with meibomian gland dysfunction, whenever we're doing any of the advanced therapies, this is an awesome adjunct to our efforts. So the question now becomes, well, wait a second. We've heard a lot about meibomian gland dysfunction, but what happens if there's an associated rosacea with the meibomian gland dysfunction that we're seeing? Rosacea is an interesting condition. It's this diffuse dermatological inflammation along the skin, and we typically see it along the cheeks and the nose. But that's not where it's isolated. It actually involves the meibomian glands and the lid margin as well, too. And we think it involves that for a few reasons. One, embryologically, the meibomian glands stem from the exact same region or from the exact same cells that the sebaceous glands on the face actually stem from. But there's a massive amount of differentiation that occurs. The challenge is, and what we think is occurring here is that this diffuse inflammation along the face is actually promoting inflammation in other regions as well, too. So not only are these patients more susceptible to their meibomian glands becoming inflamed, but the inflammation that's more diffuse on the face is actually more likely to get into that lid margin, causing some of this disease. So how do we treat this? Well, I'll share with you, and this is an important point for the males on the call tonight. And I certainly was uncomfortable having this conversation as recently as 2 years ago. Whenever I'm treating a dry eye patient who's a female, I always ask them if they're wearing any makeup. And the reason why I ask that is because I want to know if they're covering up the natural appearance of their skin. If they say, no, I'm not wearing any makeup, the second question I ask is, are you using any moisturizers or anything with any pigments in it or any type of like cover up in it? Because oftentimes they'll say, well, I'm not wearing any makeup, but then they'll say, oh yeah, I did use this moisturizer that has this pigment in it or that has this color in it. Or I use some women will even tell you, the only reason I wear makeup is to cover up the redness. So we have to ask those questions because that really creates a different treatment pathway for these patients. So there's two real ways to treat these patients. One is with medications, and two is with procedures in the office. I'll go over the medication route first. Doxycycline is the one that we've had for the longest period of time, and dermatologists use this all the time for patients with rosacea, both facial and ocular rosacea. We use it specifically for ocular rosacea. And there's been this debate in the literature on what the dosages should be. One of the best studies that I looked at, and this is back from 2005, is individuals taking either 20 milligrams twice a day or 200 milligrams twice a day. And what they found were individuals that were randomized into the two groups. They really didn't see many clinical benefits with the 200 milligrams versus the 20 milligrams. But what they did see was an increase in the side effect of doxycycline, which is what's shown on this slide. So those are things that you need to be cognizant of if you are prescribing doxycycline. What's also interesting is that topical azithromycin actually has a very similar effect to meibomian gland dysfunction along the lid margin, although it won't have its larger therapeutic effects on the rosacea on the skin. What's also interesting is that oral azithromycin has been studied against oral doxycycline. And again, you can see the specifics of the study here, but essentially what they did was they looked at individuals taking a Z-Pak versus 200 milligrams of doxycycline per day. And what they found was very, very little difference between the groups. So if you're going down the medication route, that's the route we're thinking. If you're going down the procedural route, we're now thinking about treating the eye with some type of light therapy and what's oftentimes globalized as photobiomodulation. What does that term mean? It means leveraging the power of light to help improve patients' functionality. So there's two real technologies that fall into this bucket or this category. Intense pulse light therapy, which as its name implies, it's intense pulse light applied directly to the skin, usually with some form of gel that's placed on the skin. Low light level therapy is a little bit different. You can actually either apply it to the face through masks that are available, or you can have people sit under panels that deliver low light level therapy to them. And different wavelengths will target different things, whether it be pigment, whether it be blood vessels. And what we're really interested in when we're talking about meibomian gland dysfunction and facial rosacea that we believe is causing ocular rosacea or meibomian gland dysfunction is really signaling that light so that it's targeting the red blood vessels, not only in the lid and the lid margin, but also more globally on the face, really choking those blood vessels off that are dilated and releasing these inflammatory mediators and markers. We sometimes forget the power of nutrition. And we sometimes think globally like, well, okay, our patients are using omega-3s. We know that omega-3 has an anti-inflammatory effect to it, but why aren't their eyes getting better? Well, I'll give you just one important nugget to this. If somebody tells you they're using fish or taking fish oil, that's not necessarily equivalent to omega-3s. There's one thing I want you to remember leaving about omega-3s tonight. Excuse me, two things. I'm already fibbing. The first thing is when to take the omega-3s, and that is with a meal. That's the most important thing that you can do, because when you look at the absorption, it increases anywhere from 200 to 400% when you take it with a meal versus with an empty stomach. You also reduce the chances of side effects with the omega-3s if you take it with a meal versus on an empty stomach. The second thing is you can actually, there's a quick litmus test to determine the quality of the omega-3s that a patient's taking. And the way that we do that in the office is we ask the patient to either text or bring in the omega-3 that they're utilizing. And if the total omega-3s in the supplement to the total fish oils is greater than 70%, that's a good quality fish oil. For those that are a lower percentage, that's probably a very cheaply put together fish oil and not necessarily of any therapeutic benefit to that patient. So to be clear, if you have 1,000 milligram fish oil capsule and you have 300 milligrams of omega-3, that's 30% of the total fish oil is omega-3. That's a poor formulation. But let's say, for example, you have 1,000 milligram fish oil capsule and 750 milligrams of omega-3, or a combination of EPA and DHA. That is the show of a good quality omega-3. Now, the good news is that we have a number of ways to control inflammation on the surface of the eye. Cyclosporin is available in a number of ways. 0.5% as Restasis, 0.09% as Cequa, 0.1% is available now as Vercasia, FDA approved for vernal keratoconjunctivitis, and also from Harrow Pharmaceuticals. And we now have a 0.1 formulation in Vevi as well too. There's also lifitegrast at 5%. Lifitegrast also controls inflammation through a little bit of a different pathway than T cell modulation, which is the cyclosporin pathway. It actually inhibits the interaction of intracellular adhesion molecules, which are upregulated on the surface of a dry eye, and it prevents them from interacting with lymphocyte functioning antigen 1 receptor on T cells that will bind to that. So it actually binds to LFA1 and prevents T cells from interacting with an inflamed ocular surface. And it's good to control inflammation throughout dry eye. And there's also a medication that's actually going through clinical trials currently called Reproxalap, which is a RASP inhibitor. RASP is an acronym that stands for reactive aldehyde species. And aldehyde is available and it's present in all of our body systems. But in times of inflammation, it's upregulated. So what this drop will do is it'll capture the active aldehyde species, it'll create them and make them inactive, and it'll essentially reduce inflammation through that aldehyde pathway. Now, fortunately, we know that we have other ways to actually control inflammation through corticosteroids, and we have a plethora of options that are available here as well, too. We also know there are other ways to reduce inflammation. Neurostimulation is one that's getting or gaining more attention. So the only way that we currently have that's FDA approved in a pharmaceutical manner to improve tear production through the stimulation of the trigeminal nerve is varenicline that's delivered to us through a nasal spray, commercially available as Tyrvaya. And what a patient does twice a day, separated by about 10 to 12 hours, is they spray on the inside of the nostril. Now, here's the good news. You don't jam it up the nostril. You just touch or you just squirt it on the inside wall of the outer nostril on both the right and the left side. And a patient can blow their nose almost immediately. Don't feel like it has to sit inside the nose to actually become active. It hits its target receptors very, very quickly. So as soon as they spray, they can actually wipe their nose and blow their nose if they need to. The good thing is that reduces their chances of having that reflexive sneezing response. The reason why I share that is because, again, we've seen rapid reduction in inflammation when individuals have been utilizing that. There's another category of patients that I'm going to share with you in a moment where we've seen a really interestingly positive response with varenicline nasal spray. Now, one thing you'll probably not hear about at most dry eye continuing education programs is punctal occlusion. Well, is punctal occlusion still present? Is it still being done? I would make a hard argument to say, yeah, in the appropriate candidates it is. So some of you may be wondering, well, wait a second. What's an appropriate punctal plug candidate? My criteria is easy. And I try to, with all the science that I have, I try to take that and leverage that science and simplify it as best as I possibly can to give me good, actionable clinical steps. So what I do here is every single time we see a patient, we take inflammatory readings. And we want the inflammatory readings to either be a negative or a trace positive before we would consider placing punctal plugs in the lower puncta and potentially even in the upper puncta. And the reason why that is for the logic that we've always been taught about waiting to do punctal plugs until we reduce inflammation. The only difference between that is we've never had the ability to measure inflammation, and now we actually do with this test. So this is my clinical gauge. It's a binary decision for me. Now, I will tell you, we're on the edge of some new technologies that are actually going to be injectable gels that are going to harden in the puncta and the intracanalicular tract, but those aren't available just yet to us. We still have standard punctal plugs, and we have silicone plugs, which I rarely use anymore. And we have dissolvable plugs, intracanalicular plugs, which I use as a mainstay. The way that we place them in the eyes is usually with jeweler's forceps. I've tried every single fancy forceps, and I always revert back to the jeweler's forceps. You're going to find out why in 2 seconds. It actually gives me the ability to do two things with one tool, and you're going to see what that is in just a moment. So if we're talking about permanent, usually we're dealing with small or medium plugs, and those are the silicone ones, the non-dissolvable ones, the ones that you can actually see the head of them. When we're talking about intracanalicular plugs, when these are placed, you actually can't see them, and they last anywhere from 10 to 14 days for the temporary ones, 3 months for the semi longer lasting ones, and 6 months for those ones that last a longer period of time. And again, there are a variety of sizes that are present. We always test with collagen plugs initially, which is what you can see on the right-hand side, just to determine what the appropriate size of the plug needs to be when we're placing it in the eye. And it gives us a good test at a very, very low cost because the collagen plugs are very, very low in cost. And you can see when it's placed appropriately, either the longer lasting plugs or the plugs that don't last quite as long. When placed appropriately, you can't see the head of the plug because it's now tucked into the intracanalicular tract. Now, what I love about jeweler's forceps is this right here. Take a look at the left-hand side video. We pre-dilate every patient before we actually put the plugs in. And what you're seeing here is me placing the jeweler's forceps in the puncta and just literally releasing the jeweler's forceps, allowing it to open in the puncta, just simply stretching that puncta out slightly so that we can usually get one size larger of plug in the puncta than we thought we could prior to that dilation. So again, two functions with one tool. Again, I just love those fine tip jeweler's forceps for that purpose. And when we place it in the appropriate candidates, you can see the clinical results are very, very easily seen here. On the left-hand side, you can see how the patient presented 2 weeks later with a dissolvable plug that's likely already dissolved at that 2-week time point. You can see the level of resolution that's occurred by just simply holding the tears that patient's producing on their eyes there for a longer period of time. There are a few other technologies that I want to briefly touch on here before we stop. And then Ariel, I'm going to open it up to questions as well too. I know this has been a whirlwind of information here. Again, I want to make sure I'm delivering the most clinically relevant information on all of these topics. Is albumin eye drops. Now, we usually prescribe albumin eye drops at 5%. It's made at compounding pharmacies, and it's essentially increasing the viability of ocular surface cells. And it's typically dosed anywhere from 4 to 6 times per day for individuals that are utilizing it. There's also autologous serum that's utilized right now as well too. It's derived from blood serum, and it's typically combined with a preservative-free artificial tear. It's usually dosed multiple times a day. And there are now companies that actually specialize in creating and making these serum tears for patients, specifically vital tears. There are other tools that we need to keep in our tool belt. This is where we start thinking about the more severe patient, the individual that we're potentially treating, and there's not an adequate resolution of the keratitis that we're seeing on the ocular surface, even through rounds or bouts of additional treatment options. And in this instance, we can leverage the power of amniotic tissue because we know it has a strong level of regenerative power. And this is available as cryopreserved amniotic tissue, and it's also available as dry amniotic tissue. The difference between the two, the cryopreserved, as its name implies, has to be kept in a freezer, and it actually has its own small, tiny little ring that holds it in place on the ocular surface. The dry amniotic membranes usually have to be placed on the cornea. A contact or a bandage contact lens is then placed over the top of the amniotic tissue to hold it in place until dissolved. There's now companies that are looking at the regenerative powers or the restorative powers of amniotic tissue and saying, hey, can we deliver it to the clinician a little bit more conveniently? And we now have Regenerize and Regenerize Light, which is simply a lower concentration of some of those molecules. And this is an interesting technology. It's actually a bioengineered protein, natural biologic ophthalmic solution extracted from human placental-derived biomaterials. All the biomaterials were obtained from full-term healthy pregnancies with full maternal informed consent and full screening. And those cytokines and growth factors and chemokines that actually provide that regenerative power of the amniotic tissue is actually placed into these eye drops, providing the clinician a convenient way to deliver it to the ocular surface. Now, something that you need to be cognizant of, in particular when you start doing this at a high level, are those individuals where you see staining with very little pain. And that individual, you need to be hyper cognizant that you may be dealing with a neurotrophic keratitis, because even a stage 1 can progress to a stage 3 very, very quickly. All the corneal surface has to do is become compromised by something that lands on that ocular surface. We've seen eyelashes compromise the ocular surface enough to cause it to go to stage 2 and stage 3. So again, you need to be hyper cognizant of this because there's a lack of appropriate neuronal support for the ocular surface, specifically the epithelial layer. The way we test this is corneal sensitivity testing. We either take a cotton wisp off the end of a Q-tip or a dental floss, and we touch the cornea in different regions, and we assess the viability. Now, although the other therapies that I just talked about can actually be leveraged for neurotrophic keratitis, we now have a commercially available form of a biological identical to endogenous nerve growth factor referred to as Synedromin or Oxervate that's dosed 6 times a day for 8 weeks. One thing I would challenge you to do is the Preparicane challenge. And again, as you start managing dry eye patients at a high level, this test will become much more important to you. So what is the Prepare Cane Challenge test? You ask an individual how their eyes feel right now in your office. They'll rank it on a scale from 0 to 10. You put a drop of anesthetic in their eyes. You ask them about 60 to 90 seconds later how their eye feels after that Prepare Cane drop. An individual who has all of the pain sensation occurring from the peripheral nerves on the cornea should answer that as 0, regardless of where they started. For those individuals that have a neuropathic component, these patients will oftentimes not go down very much. Why is this important to you as the clinician? It's important to set expectations early for these patients. These are probably the individuals that you're treating and asking yourself, why aren't these speed scores coming down? If you prepare cane in the eye and it does not get better, you do need to rethink that solution. We have one more minute, and then I'm going to let Ariel get back on the call here, and we're going to go over some questions here in a rapid fire way. So this is a new device called Rinsada. And the reason why I left this for the very end of the discussion is because this is really the way that we're resetting the way that we're treating the ocular surface. So what we used to do is we just used to start treating. Well, now what we do is we do a thorough rinse of the ocular surface with this device. This is a device that goes onto any basic syringe, although we purchased this with preloaded syringe or pre-filled syringes. And what it does is it goes into the upper and lower lid fornix, and it just simply puts saline in that region at a high pressure at a very intentional trajectory in order to get everything cleaned off of the ocular surface. This is how it actually looks. It was actually developed by a retinologist. The name of the technology is called Rinsada, and he was actually doing it because he wanted a more consistent way for his technicians to rinse betadine off of the eyes after he did injections. And he found these patients coming back saying that they were more comfortable and using their drops less for their dry eye. And then as he kept questioning people, he realized there was something here. He actually ran a study showing that compared to a standard ocular rinse, he reduced the inflammation levels substantially lower than just a standard rinse. Ultimately, guys, at the end of the day, when we're talking about treating this group, this subset of patients, we're talking about doing two things, providing relief for these patients and improving their function. And I'm a strong believer that if we can improve the functionality of these patients, we will provide relief as well. I tell individuals or patients that my goal for them when I'm treating them is to try and mitigate the need for a lot of the rescue drops they're using, which are oftentimes for these patients artificial tears. And I tell them, I say, my goal is to make you feel less dependent on those things that you're currently using so many times that you're in here complaining to me about.